What's going on, everybody? Welcome back to the show. This is the Science Dispatch Podcast. My name is Cameron English. Very excited to be with you, joined as always by Dr. Chuck Dinerstein, Director of Medicine at the American Council on Science and Health. Chuck, what is going on?
They're sanding the floors in my house. I had to move out, so I'm in a new environment, and it's spring though. It's spring. I can't tell you how excited I am to see that the winter here in the Northeast is over.
Well, I'm excited for you on both fronts. I'm with you there in spirit. You not being in your home, it sounds very challenging, but we're going to get through this together. We're doing something different today, folks. We have a special guest joining us. I'm talking about Dr. Lynn Webster. Dr. Webster, frequent contributor to our website. You like to take on, I want to say, what may be the most controversial topics in the science and health world, and that, of course, is drug policy, pain control. These are always incendiary topics, so I'm really excited to talk about this recent article you wrote for us. But before we get there, introduce people to you. Who are you? What do you do? And then we'll move on from there.
Sure. As you just said, my name's Lynn Webster. I'm board certified in pain medicine, addiction medicine, and started in anesthesia. So I'm triple boarded in those fields. I've practiced in the field of pain medicine and addiction medicine most of my career. I've done clinical research, mostly in drug development, but some device development. I've done a great deal of work in human abuse potential studies for the pharmaceutical company, among a few other things.
Let me ask you this quick question, because the stereotype of an anesthesiologist is the person that likes his patients unconscious. And it appears to be your whole career has been spent really in dealing with people that are wide awake and having a doctor-patient relationship that's really out of the ordinary for anesthesiology. What do you think kind of drove you in the direction of pain management and away from what we would classically think about an anesthesiologist doing?
Well, you're right. Most anesthesiologists like to stay in the operating room, and they're not usually the type of people like to have an interaction, or that's not where they get their kicks. For me, it started because I started in an acute pain service some 40 years ago. It was just at the beginning of the field of pain medicine as it began to evolve and emerge. And the acute pain service in the hospital where I was practicing as an anesthesiologist was extremely rewarding for me. I mean, I made a difference in people's lives that I never thought I could do. And as a result, I saw opportunities to really make a big difference for a lot of people. And so that's where I got started in an acute pain service. And I thought that I could have a greater impact by seeing patients and treating their pain, which was, of course, then and still is largely untreated problem.
Interesting. So you kind of went from hospital-based to office-based. We both grew up in the same era, and I can remember when I discovered that, I was a vascular surgeon, so we had a lot of patients come in with rest pain, and we'd be a day or two before we got them into the operating room. And I discovered, if you could get somebody to put in an epidural, the pain was gone. We no longer had, it wasn't like when we were in school and you learn, 75 of Demerol and 50 of Visceral every 3 hours.
Correct.
And it made a huge difference.
Yeah, I was one of the first places in the country to begin using epidurals intraoperatively, preoperatively. And as a vascular surgeon, I'll tell you, one of the hallmark cases for me was placing a thoracic epidural in two people. One was a lady was going to have a pneumonectomy for cancer, and it was the first time I had ever placed a thoracic epidural. She went to sleep without feeling any pain and woke up without feeling any pain. She had a thoracotomy on her left side. She raised her hand in the recovery room above her head and stood next to the gurney to show me that she was pain-free. And prior to that, these patients, as you probably know, many of them went to the intensive care unit and were in the intensive care unit on a ventilator for 24 hours with an infusion of opioids just so that they could expand their lungs. But another one was an abdominal aortic aneurysm resection. I did the same thing. The guy went to of course, I had a lot more challenges with him because there was a lot of fluid shifts that I had to manage there. But the epidural was what made me feel like I had a whole new career. I was a pioneer in the field at the time. No one else was doing this. And I felt I thought every generation, there's kind of a new thing that happens. Today it may be mRNA, that we get involved with. But back then, pain relief perioperatively that then evolved into the chronic pain field is where I thought I had a place.
And interesting, one last thing, and I'll give it back to Cameron, is that obviously you were part of that original wave of pain practitioners. And
correct.
That made a huge, I think that makes a huge difference in viewpoint over time.
Yeah, no, I think I have. Yeah, I have a history that few people have. Of course, most people aren't as old as I am, so that's part of the issue.
I hear that. Okay, young'un, it's your turn.
Okay, let me see if I can live up to this pressure. So, Dr. Webster, this article you just wrote on our website, it's called "Safe Drug Sites Haven't Failed, Federal Policy Has." And as I said, this is incendiary. Everyone's got an opinion on this. Everyone's freaked out in one way or the other. So maybe just introduce us to the argument that you're making here. And what I like, as I was reading this, is that you're not promising the world. You're not saying, I have the answer, everything's perfect, just follow my directions and we're going to solve everything. You're actually being honest and you're saying, there's no easy fix here. The solution is going to be multi-pronged. We're going to have to do different things. Maybe something will work in one case, it's not going to work in another, and so forth. I really like that approach because it's honest and it's realistic. But maybe give us an introduction to what these safe injection sites are and what value they have in your judgment.
So you really summarized it very well. I mean, I take issue with the almost black and white issue that the Washington Post authors suggested. I mean, they said that harm reduction sites do not help. They actually may harm, and there's proof. Well, that's just not true. That's just flatly not true. Now, as you just said, I don't contend that harm reduction sites are the solution. I think that they may be a part of a way to help mitigate harm. It buys time. It helps us provide support for people who aren't ready for a more aggressive treatment. It's just it's one of the different tools we have that can be useful. And as I said in my article, I mean, there is an enormous amount of evidence that these harm reduction sites worldwide have helped. But they take an example of a few sites in a few cities and use that data to say, well, they haven't demonstrated public-wide, population-level kinds of improvements. Well, we all know you can't take a small site, because it's all about scale. You can't take one or two sites in a couple of cities and not see a population level change in overdose deaths and draw any conclusions about the effectiveness of harm reduction. I mean, that would be a spurious kind of conclusion in my view. So I'm saying, I mean, it would be, the analogy is like, you know, you have massive forest fires and you got 2 or 3 people with their garden hose trying to put out the massive fire. You're not going to have any clinical impact. You're not going to have any real impact on those massive forest fires. And that's what we're seeing with these, with the data that we have, because frankly, it's the laws that prevent us from having a laboratory large enough to be able to design the studies to see if there is an impact on the harm reduction sites. So, I mean, that's why I argue that it's really the laws that are failing us. We don't have the laws that permit us to have the sites. And now, because of the argument that we haven't been successful in reducing population level overdose deaths, that they have failed. No, it's the laws that have failed. And it's only a tool to help us buy time until the people who are having problems can find a way to get additional support and help, and maybe help with their problem of addiction. And stay alive. It's about staying alive.
So ideally, how would this work? Because just speaking frankly, I'm very skeptical of the idea that we should provide people a safe place to do drugs. I get the motivation behind it, but as a father with young kids at home, it just sort of, and maybe this is a little irrational, frankly, but it just, like, I hear it and my dad brain goes, no, I don't think so. So I do want to kind of drill down into the specifics. But before we do that, in your ideal world, how does this work? Just ballpark, do we need sites in every city? Do they need to be run according to a set standard? Like, what would you need to have a definitive answer about how these sites would work effectively? Does that make sense?
Yeah, you're asking how can we determine if they're effective?
Yes.
Okay. Well, first, I think you can look internationally. There are like 92 countries that have demonstrated that they've been effective. They've been around for 30, 40, 50 years. And so we can take a look at data that's out there. It's not in the U.S., but it is as close as Canada. And even though the authors of the Washington Post article said that there is little or to no evidence, that's just not true. There's an enormous amount of evidence of their effectiveness in reducing overdose deaths. Switzerland, for example, has gone down to a small number of overdose deaths when they were exceedingly high. Portugal has done the same thing. Australia has done the same thing. So we've got dozens of countries who have implemented harm reduction programs, not as a solution to treating addiction problems, but as a means to keep people into the system alive until they can be transitioned or they're willing to receive additional treatment. To answer your question, how do we do this? Well, we obviously need laws changed, but let's assume that there are no legal barriers here. Then I think we need to have them where the problem is. We need to go and have enough sites in enough locations that we can actually assess and measure the impact that they have. If it's going to be population level, then it has to be a large number of sites throughout the country that would have the ability to provide this. You can't, as I just said, you're not going to take a garden hose and put out a forest fire. Right? So you need to have enough sites monitored. And by the way, there is no evidence that there's any greater disruption in the communities with these sites than before. In fact, without the sites, the individuals who are using them would be on the street, in the bathrooms, in the public parks, using the drugs. So it's safer, in my view. But I understand your perspective and others out there that they don't want them anywhere in the county. But they're in the county. They're there. And so what are you going to do with them? Say, go to the park and get underneath the park bench and do your thing? Or are you going to say, come here where we can monitor you safely, and you're really isolated then from the community, the public?
One of the things that I saw looking at your website, and I think that's pertinent here, is you're very pragmatic about things. And once you move the site out of the neighborhood, you have a whole other set of problems with transportation and
right.
and issues like that. So it certainly makes sense to locate things where the people are. That's clear. And I think the other distinction that has to be made when you talk about this is that it is an appeal to keep the patients alive long enough to get them into a system where you can start looking at addiction recovery. And exactly. I think that there's a lot of conflation when we talk about what the metrics are. When your metric is, did I cut overdose deaths? Yes, that's there. That's not the same thing as have I gotten 20 or 30% of the people off drugs forever. which is a different metric. That's not you want to talk about these centers as a gateway. It's a gateway away from drugs.
A gateway away.
Fair enough?
It's a step. It's a step in the process. I think of the whole problem with substance abuse, whether it's opioids or alcohol or something. I mean, we've got three different levels of treatment. We have the individual, which is what the medication-assisted treatment plans are. Morphine, buprenorphine, naloxone. That's an individual treatment. Then we have like the harm reduction sites, which can reduce the amount of transmittable disease, hepatitis, HIV. Those are very costly to society as well, and it keeps people alive. But ultimately, if we want to reduce the number of people who develop a substance abuse problem, then we have to look at structural issues. That's a big topic to discuss. That's what my book is all about, that will be coming out soon. And it is a bigger challenge to deal with the latter because it's complex. And because we have institutionalized biases against and moralized against a medical problem, and actually developed laws, just like we see. I mean, the crack law that is being applied in this case to prevent injection sites applied for the distribution of crack in crack centers. It wasn't about the way in which we're trying to provide medical support for people until they can advance to another level of support with harm reduction centers. Much different.
There was a study put out I guess it wasn't a study, it was a review by the RAND Corporation in 2018. And I found out about it because there's a lot of harm reduction advocates that would cite it as evidence that policies like safe injection sites work. And when I read it, one of the things that struck me is that some of the objection, not all of it, but some of the objection to setting up these centers comes from addicts themselves. So, and some of them, and I think you mentioned this in your story, some of them are concerned about stigma. They're afraid of going to one of these centers and then being arrested. But there's a lot of them who say, I have a serious addiction problem, right? I don't want you to help me take my drugs more safely, right? I recognize that I have a problem that needs to be addressed, ameliorated, whatever. And so I'm curious, as a physician, what are your thoughts on that? When you have people, they're using, but they recognize that they're doing it because they can't stop, and they don't want help to do it in a safe fashion, right? They want to get off the drug. So what's the appropriate response? Is it going to be context dependent? Do you need to treat people differently based on how they view their own issue? Or does that complicate the discussion about safe injection sites when you have people like that who are saying, I don't want you to help me, take fentanyl more safely?
So let's be clear. I think I heard you say two things that seem to conflict. I mean, you're absolutely right. There are many people with substance abuse problems who don't want help. In fact, we look at SAMHSA has reported 75% of people with opioid addictions do not want help. Not now. Maybe in their transition, in the trajectory of their life, maybe through the course of exposure and problems, they will come to a point where they do want it. But many do not. So that's why we have the harm reduction. We're buying time. We're trying to help support those who are willing and interested in what's available there to get some support, some medical support. But we have to meet them where they are. So some of them aren't interested, and for legal reasons, they're afraid. Social reasons, because we have stigmatized them, we've moralized their medical problem as being bad, and they don't want any more of that. They don't want any of that exposure. And some people just don't want any help. We can't help those who don't want help, but we can for those who are willing to seek some level of treatment. That's what the harm reduction centers are about. So to answer your question directly, we have to meet them where they are. And that doesn't mean just physically, but where they are emotionally, mentally, and we have to reduce the barriers so that they have access to the treatment that can keep them alive until they're ready to take a more advanced step towards recovery.
Let me ask you this: when you talk about 75% of the patients on opioids don't wish to stop, a lot of what we describe as opioid addiction is behavioral, and it's antisocial. It's what we view through the lens of being antisocial behavior. They don't go to their meetings, or they skip family events, or whatever it may be. But I'm thinking now about patients with air quotes opioid addiction with chronic pain. Now, these are people that have found some kind of medical relief on some reasonable pain regimen that can be still labeled as being opioid addicted. Are we talking about those people, or are we?
Well, so now we're really getting into the meat of all of this. Let me back up, though, and clarify that I didn't say that 75% don't want treatment, 75 don't want to seek treatment. And that might be largely because of the barriers, legal barriers, social barriers that we've created, but they don't seek treatment. And for whatever reason, and it's probably all of the above. But now many people with chronic pain who are on opioids are labeled as addicted, and they're not. It's a misunderstanding that people who are on chronic opioid therapy are addicts, and that has caused an enormous amount of damage and harm to the people who have chronic pain, as well as to the people who have substance abuse problems. We have to understand that withdrawal is not an indication, necessarily an indication of somebody who is addicted. But oftentimes, our colleagues who are treating people will see somebody who's going into withdrawal, and they'll automatically say, well, you're addicted. You're not addicted. That's a physiologic neural adaptation to an exposure to a substance that changes the set points of our receptors. So we will all go through withdrawal if we're on opioids for a length of period, 3 months, 6 months. If we're on a daily amount, we're all going to experience withdrawal. That's not addiction. That's a physiologic change that's occurring. Chronic pain patients are all going to have that experience if they're suddenly discontinued from their medicine. Now, what is the reason you seek the drug is a real issue. Are you seeking it for pain relief? Well, if it's pain relief for emotional reasons, that's a problem. If it's a pain relief for a physical problem, that's a different problem, and it needs to be treated differently. Oftentimes, people have a combination of both. That's really challenging, and that's what my field, or people with addiction training, are trying to sort out with the patients and make sure that if they're taking an opioid, that they're taking it for the right reason, or if it has taken over the control of their life, maybe they need medication-assisted therapy, and maybe for a long time, maybe for decades or the rest of their life. We know people can live 50 to 70 years since the 1950s, that they can live very well with methadone for the rest of their lives and be very functional. That's not addiction. They may have developed a dependency early on that was physical, but with the withdrawal were diagnosed as having an addiction. In fact, I know many patients I treated who had come from an addiction treatment center, a methadone treatment center, who were not addicted. But it was the only way they could get the opioid that they had been placed on for a medical problem and be able to slowly taper off. They had to go to a methadone treatment center. There's a great book by Travis Ryder. If you, I hope he pronounced his name there properly, but it is his experience of having gone through multiple operations after a motorcycle accident, and at Johns Hopkins struggled to find a doctor who could take him off of the medicine. They all said he was addicted and that you just need to get on methadone and stay on it the rest of your life. I suggest anybody who wants to understand the complexity of this issue, read that book. That's not addiction.
Let's broaden the scope a little bit. I'm really curious to get your take on drug legalization more generally. There's a number of experts on this topic that talk a lot about, making sure that patients get adequate pain control, who will just say, we need over-the-counter opioids, right? We need people to be able to go into a CVS, say, and get the drugs that they need or that they want because you have a regulated supply. It's not going to be contaminated. It's the sort of anti-prohibition arguments that you typically hear. We had Dr. Jeff Singer on this podcast who made that case. And again, it seems to me like overkill. It seems like it's gonna do too much. But I'm curious, what's your take on that? Is that just sort of the fix here, or are the benefits greater than the risks that would come with a policy like that? What do you think?
Well, as a general statement, I think we cannot. We can't open the doors to opioids or any other controlled substance. We still need to have them. We still need to control their distribution and use in some way. I do not believe that they should be over the counter. And I think that we need to be wise about this, just like any other medication, potent medication that can be lethal or not. I mean, a lot of medicines aren't lethal, but they still need to be prescribed because you need to know how they're being used. So I do not believe in legalizing over-the-counter controlled substances. Now, I think changing cannabis to a Schedule III should have been done 50 years ago, because that was all, of course, done for racial reasons. It was all to control the black population, to make it an unscheduled drug, a non-scheduled drug. And I think the same thing is with heroin and with a number of other drugs. We need to have a thoughtful way to approach this and to monitor it appropriately, but make it available. I think the real challenge here the real problem are the legal barriers that prevent us from looking at it from a scientific perspective and to measure the outcomes appropriately.
You've said a few times now that this is a medical problem. And to a certain extent, it clearly is, right? If you're dealing with people that have a substance dependence issue or they're sick and they need pain control, obviously these are medical issues. But to what extent is it bigger than medicine? Some of the research, if you look at it, having two parents in the home, not being exposed to drug abuse as a child, these sorts of things, I don't want to imply that it's perfect, but they sort of safeguard you against the risk of addiction, or they lower the risk of addiction later in life. And I'm wondering, is there a way to eat into the demand for recreational drugs, right? Is there a way that we can protect people before they get down this pathway that can be so destructive? What do you think?
Yes, absolutely. A large part of the reason we have so many people using drugs is because of deaths of despair. I mean, that's part of it. The structure of our system, our healthcare system, the legal system, the economic system, and the homelessness. These things are all components of what have created the need to find some substance to help them be relieved of the suffering they have, whether it's a physical pain, but mostly an emotional pain. So yes, there are a lot of things that need to be done for the prevention. As I said, there are three tiers. We've got the individual, which is the medication-assisted therapies, buprenorphine, naloxone, naltrexone, and methadone, and then we've got this in-between area like the harm reduction, which buys us time, treats them where they are, where they are medically, but also where they are emotionally, where in that transition, hopefully, towards a more complete recovery. But if we want to prevent the number of people who are seeking out drugs, the demand, that's a much larger problem, and it's a much larger issue, and it's really the issues of deaths of despair and the economics, the homelessness, etc. We have to provide economic support and structural support for that to be minimized.
So there's a quote from you on the website. I went and I took the test on the website to see whether you were, I guess, your tendency towards addictive behavior, and I was interested in
the ORT.
Yes, because it was primarily looking for genetic and then environmental things. And then you wrote, for too long the nation has relied on enforcement and supply reduction while neglecting the conditions that make people vulnerable in the first place: unstable housing, untreated trauma, lack of opportunity, and fragmented care. And it seemed to me that of all of those, fragmented care was the lowest of the hanging fruit, and that a safe injection center was, again, that entry step into taking fragmented care and having the appropriate handoffs and consistency and continuity that's necessary. And the other point that I want to make, that as I was listening to Cameron, is I think that the term recreational drugs is in many instances a misnomer, especially when you're talking about heroin and fentanyl. I don't know whether people are using it for recreational purposes so much as to numb some kind of psychological pain. And I think we need to make that distinction too.
You're right. If you were to look at any one assessment tool to assess what the risk of developing a substance use problem would be today, it's probably the adverse childhood trauma assessment, because that is correlated the most that I've been able to find with the prediction of substance use problems later in life. And it's long. It's not just an episode of substance use. It's really across all health problems as well. I mean, all health is predictive by your ACE score early in life.
Let's kind of drill down on that a little bit. Maybe non-medical is a better term, Chuck, than recreational. Because all I'm trying to do when I talk about this, I'm trying to distinguish between someone, for example, and Dr. Josh Bloom wrote about a patient like this who had metastatic breast cancer and was taken off OxyContin by the nursing home that she was in, because of these sort of nebulous beliefs about addiction that you've written a lot about, Dr. Webster. So someone like that, a patient in that condition who is just going to be in unbearable suffering without pain control, at least in my mind, is in a different category than someone who starts to use drugs to mitigate some sort of emotional suffering or trying to grapple with some sort of trauma. Those are just two different categories of people. One isn't better than the other, but they have to be treated differently. And I think this is one of the mistakes the harm reduction folks tend to make, is they tend to conflate people who belong in different categories, right? They blur distinctions because it's easier to make their case when you do that. So that's sort of my thinking, Chuck. And then if either of you have thoughts on that, I'd be glad to hear them.
Well, I don't think you paint everybody with the same brush, So you're right. The case the situation that Josh talked about is, I think, pretty straightforward, but it's less difficult, it's more difficult to understand what the reasons are why people use it for emotional pain. And when you're talking about harm reduction, it doesn't matter, really, what the source of their driver is. They have a driver to use a substance abuse problem, and so they need help. And it's still medical, even if it is emotional, even if there's childhood trauma that is the seed to their behaviors of using substance abuse. That's still a medical problem. Now, how we address that medical problem is not going to be the same as we address the cancer patient who is on the oxycodone. But that's why it's a medical problem, and we can't use laws to tell us how to treat patients, because they're both patients. Both categories are patients, and it isn't binary either. There are people that can have physical pain and emotional pain, and it can transition from one to another over the course of their life. In my practice, I saw people who came in with physical pain, but because of the effect of physical pain on their life, they end up with a divorce, they're unemployed, they're now even homeless. So the pain moves. It's migrating from physical or being, there's an additional amount of pain with the emotional component. How we treat all of those has to be done carefully and individualized, but it's still a medical problem. And we have to, that's part of what the harm reduction people are trying to do. And I don't speak for harm reduction people or the sites. I'm only speaking for me. But I think that what we need to do is be sure that we meet people where they are and provide them what we can provide them that makes medical sense to keep them alive and try to move them towards more complete recovery.
Let me take a different tact on that. I mean, the reason I keyed on a recreational, because it sounds like such a, happy, it's just something I'm going to do for the fun of it. And so we can choose, and we just tend to use that word, and we don't think about the consequences of how it plays back in our heads. I think the other thing that Dr. Webster keeps getting back, when you talk about you have to meet the patient where they are physically, you have to meet the patient where they are mentally, is that we're talking about relationships that are very difficult to scale. You can't do good addiction recovery in any way you want to think about it at scale. What you can scale is some of the harm reduction gateways to get them in long enough to have a conversation with them, and then find an individual path for them, because everybody's going to be different. I think that one of the great problems is that on the public health side, we look for something that's easily scalable. So what we see now is, I don't know of, I've had 2-3 major operations in the last few years, and if I get some Tylenol number 3, I'm a lucky dog. I came home from open heart surgery with some Advil, with a sternotomy, and so, for the doctor's side, it was real easy to scale. Everybody just stopped giving out drugs, But I think that when it comes to other subgroups in here that have a trauma or other associated kind of issues, scaling doesn't work real well.
Let me just add to the conversation about recreational drugs. I mentioned at the beginning that I have worked on developing or assessing really drugs of abuse potential a lot in clinical research. And the population that we study, we expose them in clinical settings. We invite people in, we recruit patients or subjects rather into studies who admit that they take it for fun. That's the reason they take it. They take it for fun. And back 10, 20 years ago, that was very common. Less so today, but it was very common back then. They would take diverted oxycodone, OxyContin, hydrocodone drugs, and they would take it just for recreation. In fact, one subject once told me that if he has that available, it's easier on a weekend than a 6-pack of beer in his car. So because it's legal for him to have the prescription drug. Now, I only say that because that's the population who actually use controlled substances for recreational purposes. Up until this point in my comments have not addressed those patients or those people. They're not patients. They are having fun. It's the person who drinks the beer on the weekend, at the football game. The people that I've been addressing for harm reduction are not those people because they don't have addictions. By definition, they can't be enrolled into a study. They just use a drug recreationally on an occasion, and they like the experience, and then they move on. And often, by the time they get into their 30s, they stop using the drugs. For some reason, they just transition away from it. So Using drugs recreationally does occur. We know it happens, but that's not the population that needs harm reduction.
Yeah, that's a good clarification. The final observation. I read a book a little while back called "Life at the Bottom" by Theodore Dalrymple, who treated addicts for a long time in a low-income area of London, in a hospital and an adjacent prison, because you have a lot of people going to prison that have addictions. And he talks about people that he saw, hundreds of cases of people they started to use for fun, and then it becomes an addiction over time. So, and again, I'm not trying to put people in that category that don't belong there, but there are clearly cases. He gives the example of one young woman where he's interviewing her and he says, "Why did you start to use?" And she goes, "Because the drugs were there. My boyfriend gave them to me." Right? And so the argument he's building there is that people do have agency. They make decisions and they have to be accountable for those. It's not that there aren't other factors that influence how they behave. Nevertheless, there is still a choice involved, and sometimes people do make bad choices. And so it's not to paint everyone with the same brush as you said earlier. It's just that there are cases where people make bad decisions, and we should be frank about that. That's all I was trying to get at when we started this subplot.
Well, I agree with you.
Okay.
By the way, I agree with you. There are people who make bad decisions. I've made bad decisions. I mean, I think we all make some bad decisions. Some of them are badder. Some of them are not as good as other decisions. And just so we cover the bases here, opioid addictions. We know that there's a very strong genetic component. About 50% of the risk of developing an opioid addiction is genetically based. However, that doesn't mean if you have a genetic vulnerability that if you were exposed to an opioid that you're going to go on and develop it, because there are environmental protections. I mean, our environment can either facilitate the development, as is the case that you just gave. Her boyfriend gave it to her. That's part of her environment. And she just thought it was the way to go forward. And then she develops a physical dependence. And then she has withdrawal. And then she can't get out of it without some help.
Very good. I really enjoyed this. I could keep talking about this for another hour, but I'm not gonna abuse your time that way. So as we wrap up here, what's the way forward, right? Give our audience some takeaways about at least how they should think about this appropriately, right? Obviously, we're not the president. We are not running the DEA, as interesting as that would be. But what's the way forward, ideally, in your view? Well,
I think we need to first realize that addictions, though there is some agency with individuals, that there is a big problem, and that those who have the problem, whether it was bad choices or not, those who have developed the problem need individualized treatment. And we have some treatments for that. They're not as available in rural areas or equally available throughout the country in all sections, but those are they can be very effective and can save a lot of lives. But there are a lot of people who need more than that. And that's where the harm reduction policies come. And we've got laws that need to be changed that'll allow us to assess the efficacy of harm reduction techniques. And then I think, thirdly, we need to seriously look at what creates the demand. And the demand are those structural things that we've talked about, like homelessness, economic issues that have to be changed so that there isn't such a world of deaths of despair that create the need for some kind of a drug to help you out.
Very good. Well, appreciate all the insight. Where can people learn more about your work? You said you've got a book coming out pretty soon. Tell us about that. Tell us about your website.
Yeah, it's I have a book coming out by Springer. It should be out in about a month. You can go on Amazon, Deconstructing Toxic Narratives. Just look up my name, Deconstructing Toxic Narratives. I think the narratives about our opioid crisis have been incomplete and often misleading and inaccurate. So I tackled that from the demand side and outlined clearly how and why I believe that we have had such a large problem, and it's largely demand, not by supply, which has been the major narrative over the last 2 decades. So you can go on Amazon or Springer Nature, and you can find more about the book. And on my website, lynnwebstermd.com.
Very good. Well, go check it all out. I can't wait to read that. I'm sure it's going to be very, very instructive. Once again, the article we talked about today is called Safe Drug Sites Haven't Failed, Federal Policy Has. That's by our guest, Dr. Lynn Webster. Thank you for joining us as always. When you're on the website, if you like our content, if you like what we're doing, click the donate tab and give us $20. Support the work that we're doing. We love to bring experts on like Lynn, talk about this, put out videos, put out articles, so the public is more informed about all these critical science and health topics. And with that, we're all done. Thank you as always, and we'll see you next time.